Today's topic is nursing management for clients with seizures. 65 million people around the world have epilepsy. Between 2.2 and 3 million people in the U.S. have epilepsy. That's 1 in 26 people in the United States that will develop epilepsy at some point in time. Between 5 to 8 out of 1,000 in the United States live with epilepsy at any given time, and 150,000 people are diagnosed with epilepsy in the United States each year. About 1 in 3 people with epilepsy live with uncontrolled seizures because no available treatments have worked for them. For 6 out of 10 people with epilepsy, the cause of epilepsy is unknown. National trends show that the incidence of epilepsy is decreasing in children and increasing in the elderly. The highest incidence of new onset epilepsy occurs in people over 60 years of age. New onset of cases of epilepsy are more common in African Americans and in socially disadvantaged populations. Males are slightly more likely to develop epilepsy than females. Populations at highest risk to develop epilepsy include those with Alzheimer's, those who have had a stroke, and persons who have had a parent who have had epilepsy. I've got a couple of links in this slide that you can turn to for more information about epilepsy. Let's talk about the cause of epilepsy. There are 2 different categories of causes. There's primary epilepsy and secondary seizures. Primary epilepsy is not associated with any identifiable brain lesion. And the secondary seizures are related to some sort of condition or illness or underlying disease process that has occurred, like metabolic disorders, acute alcohol withdrawal, electrolyte disturbances, high fever, stroke, head injury, substance abuse, and heart disease. Epilepsy is defined as a seizure as an abnormal, sudden, excessive, uncontrolled electrical discharge of neurons within the brain that may result in a change in level of consciousness, motor or sensory ability, and or behavior. A seizure may occur for no reason at all. Some seizures are caused by a pathological condition, and epilepsy is a chronic disorder in which repeated unprovoked seizures activity can occur. It really is a central nervous system disorder in which nerve cell activity in the brain becomes disrupted, causing seizure activity or periods of unusual behavior. Epilepsy, which is a chronic condition, is defined by the National Institute of Neurological Disorders and Strokes as having 2 or more seizure-like activities. There are several types of seizures, and seizures are classified into these categories. There are 3 broad categories, including generalized seizures, partial seizures, and unclassified seizures. There are 6 types of generalized seizures that present with a variety of clinical manifestations. Generalized seizures have tonic-clonic seizures, formerly called grand mal seizures, absent seizures, which are formerly called petit mal, and myoclonic seizures. Tonic seizures and clonic seizures. Partial seizures are characterized by having simple partial seizures which no impairment of consciousness has occurred, complex partial seizures which impairment of the consciousness has occurred, and then partial seizures. Let's talk about some of the common triggers of seizures. Assessing the common triggers of seizure onset is essential when caring for clients with a seizure history. Some clients find that seizures occur in a pattern or are more likely to occur in certain situations. Keeping track of any factors that may precipitate a seizure can help the client recognize when a seizure may begin. Some clients will notice 1 or 2 triggers very easily. For example, the seizure may occur during sleep or when waking up. Other clients may notice that some triggers bother them only when a lot is going on at once or during a high-risk time for them, for example, when they're under a lot of stress or when they become ill and sick. The common triggers for seizure activity include the seizure happens at a specific time of day or night, sleep deprivation, fever or an illness, flashing lights, alcohol or drug use, perceived stress. Sometimes seizures can be associated with hormonal changes, like a menstrual cycle. Specific foods can trigger seizures, excessive caffeine, and some medications. Knowing these common triggers will help clients be able to manage their seizure activities. There are several labs and diagnostics that can be ordered for the patient that has seizures or seizure activity. An EEG is ideally completed within 24 hours of a suspected seizure. Magnetic encephalography is another type of diagnostic which detects small magnet fields that generate neuronal activity to try to pinpoint where that electrical activity is occurring. A complete blood count. Comprehensive metabolic panel to look at electrolytes, kidney function, and liver function. Many of the anti-seizure medications are metabolized through the liver and will be required to sort of look at the liver function and make sure there's no impairment. Serum levels of anti-epileptic medication therapy is also warranted. Many of the medications that patients are on require that we do serum levels to ensure that they're not toxic and they have a therapeutic level to be able to manage their seizures. With new onset seizures, the physician can order a CT or MRI to look at any sort of underlying pathological condition that could be causing seizure activities, and also cerebral angiography to look at any sort of underlying circulation problems that could be the cause of the seizures. Let's talk about some of the clinical manifestations that you might see in patients that have seizures. There are several different types of activities. I've listed them out here and we'll talk about them. Tonic phase causes stiffening or rigidity of the muscles, arms and legs, and loss of consciousness. Clonic or rhythmic jerking of all extremities follows the tonic phase. Automisms, which are involuntary behaviors like lip smacking, picking at clothing. Blank staring is another form of seizure activity. Myoclonic is a brief jerking or stiffening of the extremities, and then atonic is a sudden loss of muscle tone. Other specific clinical manifestations are really geared at looking at three different phases of the seizures. One is the pre-ictal phase, two is the ictal phase, and three is the post-ictal phase. In the pre-ictal phase, the client may describe a presence of an aura, which an aura is described as a strange light or unpleasant smell or confusing thought that precipitates a seizure, and sometimes the patient will let you know that they feel a seizure is coming on based on this pre-ictal phase. The ictal phase is when the actual seizure activity occurs, and then the post-ictal phase is when the client is done with the seizure activity, and this can last 5 to 30 minutes or longer, where the patient or the client will be perceived as being confused. They'll have drowsiness, maybe even sleeping, nausea, and headaches. There are specific problems that are associated with seizures. Ineffective breathing pattern. In particular, if the client is having a seizure activity, the one thing you want to do is maintain a client's airway. Risk for injury is another problem associated with seizures. We want to protect the client's head during a seizure, turn the client to the side in case they vomit or have excess of secretions that they can't control for themselves, loosen constrictive clothing, ease the client to the floor if seated, do not restrain the client, and do not place any objects in the mouth. Ineffective coping, dealing with seizures and having this particular underlying pathological condition can be pretty stressful for clients. Provide resources for promotion of self-care so they can manage this particular condition at home, and offer some supportive groups that they can attend to help them cope and manage with this diagnosis. Ineffective health management. Some of the medications that the clients are placed on can cause adverse side effects and may cause the client not want to take these medications. So again, a lot of support and education for those clients will be warranted. The plan and the goal for these patients is the client will be free from injury during a seizure. The client will have optimal mental and physical functioning while taking anti-seizure medications. The client will have a satisfactory psychosocial functioning. The long-term goal is the client will have no seizure activity. Let's talk about some of the interventions that are important. Seizure precautions are taken to prevent the client from injury if a seizure occurs. Specific seizure precautions vary depending on the healthcare facility you work at. Be sure the oxygen and suction equipment are available to keep the airway clear. If the client does not have an IV access would be important. So insert an IV and create a saline lock. Side rails should be up at all times and padded to maintain safety. Client's bed should be in a low position, and the client should be in a side-lying position with a pillow under the head. Lastly, the curtain should be closed for privacy to help maintain dignity for this particular client. Let's talk about some of the best practices during a tonic-clonic seizure. Again, we want to protect the client from injury. Do not force anything into the client's mouth. Turn the client to the side to keep the airway clear. Maintain the client's airway and suction as needed. Do not restrain or try to stop the client's movement. Guide the movements if necessary. Record the time the seizure began and ended for this client. It will be important to understand in just a minute why timing is key. Also, some of the interventions include medication therapies. I've listed out two sort of broad categories. You have the anti-seizure medications, which include things like Tegretol, Klonopin, Depakote, Depakine, Neurontin, Lamictal, Keppra, phenobarbital, and Dilantin. Many of these anti-seizure medications have serum levels that need to be drawn to make sure that the patient isn't getting too much of the medication or not getting enough of the medication. So again, patients will have serum levels drawn. Also, some of these medications are metabolized in the liver, so making sure that the liver is functioning properly would be important before the patient starts the therapy and during the therapy, because again, some of these patients can have liver toxicity secondary to these medications they're taking. The next category is sedatives, and sedatives are used in the acute phase of seizures, in particular if there's new onset and they're trying to manage these seizures. The patient will have to be sedated in order for the actual seizure activity to stop. So these sedatives include things like Ativan or Valium, and these medications can be given orally as well as intravenously. If the seizure activity is occurring, obviously you can't give anything in the mouth, so an IV would be warranted where you can give these patients intravenous medications to stop the seizure activity. Status epilepticus is an emergency situation. This is a prolonged seizure activity lasting longer than 5 minutes, so again, timing when the onset occurred is going to be important. Or if they've had repeated seizures over the course of 30 minutes, the seizure has to be able to stop. The patient will have brain death and or die in general if we do not stop this medical emergency. Common causes that where this occurs include sudden withdrawal of anti-epileptic medications, infections, acute alcohol withdrawal, head injury, cerebral edema, and metabolic disturbances. The treatment during this is airway management. Sometimes the patients will actually have to be intubated and have mechanical ventilation. IV access to be able to give some sedatives to control these seizures and stop them. Oxygen therapy, fluids, sedation, vacation might ultimately be what the patient is requiring to stop this medical emergency. So patients again will have to have an IV access and be able to have an induced sedation coma with some of those listed sedatives in the prior slide, like Ativan, Valium, and they might actually have to be put on a propofol drip. Surgical interventions I've listed out here in this slide. These are interventions that might be necessary for clients that aren't being managed with medication therapies alone. Vagal nerve stimulation is one therapy that could be used. Resection or resective surgery, where they actually remove the area of the brain that's causing the seizures. And then they also can do an interruption of nerve pathways and try to disconnect some of that neural activity that causes the seizures. And they can actually ablate some of the actual neurons that are causing the disruption. So if we're going to evaluate the outcomes of these clients that have seizure activity, we want to be able to help them be able to manage their seizures. avoid seizure triggers or risk factors, effectively manage their medication regimen, maintain social roles that support meaning, and recognize supportive systems for ongoing lifestyle changes and self-care management. This concludes our discussion on clients with seizure activity.